is Jenna Smith, and I'm here from Milwaukee, Wisconsin, where I'm currently completing my internship at Freighter Memorial Lutheran Hospital and the Medical College of Wisconsin. Today I'm here to talk to you about PET-CT radiation burden. So I'll be comparing the entire body scan, which is scanning the patient from the very top of their head through their toes, and comparing that to the skull-base to mid-thigh scan, which is scanning the patient from about eye level to mid-thigh. So the overall purpose of this study was to determine if every patient that comes through your clinic doors can safely receive an entire body scan regardless of their diagnosis. An entire body scan on all patients would be beneficial, as any lesion large enough to be detected, even if it's down in their big right toe, will hopefully be able to be found and made note of. However, because PET-CT systems utilize a low-level CT, in addition to the already injected FDG dose, patients are receiving a large amount of radiation through the process of a PET scan. This research was made possible by looking at something called dose length product, or DLP as I will refer to it as. DLP is radiation exposure directly proportional to the length of the area being scanned. So the longer or taller the patient is, the higher the DLP value will be. I also wanted to observe any correlation in body mass index and DLP. For this study, I utilized a General Electric PET-CT system with SMART-MA. SMART-MA is where the tube current is actually able to kind of adjust itself based off patient size and density. 70 adult patients were observed in this study. All 70 of these patients were protocoled for an entire body scan. Patients had their height and weight recorded. Their height and weight were then used to calculate their body mass index. Also recorded was their entire body DLP value and their projected skull base to mid-thigh DLP value. These DLP values were done by, after their scout image was acquired, our computer system actually generated the entire body DLP value, and then after actually changing some of the parameters myself to make the computer think I was doing the skull base to mid-thigh scan, it then gave me that DLP value. The parameters were then set back to the entire body, and we proceeded with the patient's actual protocol scan. Those two DLP values were then used to calculate a percent decrease between the two protocols, and then also to perform a t-test to see if there was any statistical difference or similarity between the two scans. Results as far as body mass index is concerned, I had a wide range of patients. On the lower end of the range was a patient at 18.7 kilograms per meter squared, which was a patient that stood 4'11", 97 pounds. And on the higher end of the BMI range was a patient at 48.7 kilograms per meter squared, which was a patient that stood 5'10", 339 pounds. The patient that received the lowest radiation burden between the two scans based off their DLP value was not the patient with the lowest body mass index in the study, but rather the third lowest out of the 70 patients. However, the patient with the highest radiation burden based off their DLP values was indeed the patient with the highest BMI of the 70 patients. I also calculated that DLP decrease between the two protocols. And between the two, there was an average of 17% plus or minus 6.2%. Here is a graph representing the entire body DLP against patient body mass index. I chose to use the entire body DLP values as they were a little more reliable than the projected skull base to mid-thigh values. So what we can generally take away from this graph is that as patient body mass index increases, there is a general upward trend in the entire body DLP as well. So here are my t-test results. The left bar represents the average entire body DLP value, and the right bar represents the average skull base to mid-thigh DLP value. For my t-test, I used an alpha value of 0.05, so in the case of my research, a p-value above 0.05 is going to signify statistical similarity, and a p-value below this 0.05 is going to signify statistical difference. So after performing the t-test, I retrieved a p-value of 0.02, and 0.02 is less than 0.05. So in conclusion, what I found is that as patient body mass index increases, their DLP is also likely to increase. This is what I expected to find, but it was nice to have actual values to see this trend. This is due to as a patient has a higher body mass index, they're likely to attenuate more of the x-rays from that low-level CT. The t-test shows that entire body scanning statistically does give a higher radiation burden to our patients. So that's when we bring our friend Laura in, and I'll say that we have to continue to do entire body scanning at a minimum and for certain circumstances only. As with most research, there's always room for improvement. A larger sample size is always beneficial in any study. Also, having a mutual agreement different as to where mid-thigh actually is. It varies not only from patient to patient, but from individuals that helped me in collecting my data. Some may have had mid-thigh going a little further down towards the knee, or some may have had it a little higher up towards the pelvis. And then for future research, I just looked at the overall CT in PET, but maybe including the FDG dose would be beneficial as well. So I would like to thank all of you for your undivided attention, but I'd also like to acknowledge Beth Bates, the lead PET technologist at Freighter, Ann Vossler, my wonderful program director, and then the Freighter Nuclear Medicine Department as a whole for their help with my research.